Oh well. Okay, guys. Oh. Okay, one more try. One more thing. Hulk Hogan? Yeah, he passed.
That's crazy, but everyone's just dying.
It comes in threes, man.
Everybody's just saying, like, I'm not.
Comes in threes.
Cosby Show. Ozzy was a big one, bro. Ozzy
All right. Can y'all hear me? I can't see the messages now. I was able to man the camera for a bit, but for those of you that are online, I cannot see your messages, so you might have to unmute if you have a question. If there's anything that's messing up or you can't see, just let me know and I'll try my best to correct it. So chapter 38, like I was mentioning, it's a lot of orthopedic trauma, and it goes more of the basic stuff, which we already know how to do, right? We're all basics here. Splinting is basically one of the main things that we're gonna go for, but we're gonna add on just a little razzle dazzle on there of little things like that. The A&P review, you already know the tissues, or we should know. Are you guys taking A&P? You already took it? No? Casey? Next semester you're taking it? Okay. Well, once it goes a little bit more towards the deeper into the body, you'll see where the musculoskeletal works from there. But we're gonna get a little bit here. You have exoskeletal, which is the vertebral column, the skull, the ribs, the sternum. There's different things. We have the appendicular skeleton, pectoral griddle, the pelvic griddle, and the bones of the upper and lower extremities. The griddle. Oh, it's girdle. I'm sorry. I'm gonna make girdle now. The shoulder girdle, is composed of the scapula, the clavicle, right here. The little wings, right? Your little wings, chicken wings type of thing. The upper extremity consists of your shoulder, the elbow, wrist, hand joints, bones of the upper hand, things like that. The majority of the hand function comes from the muscles in the forearm. Long tendons extend to the hand and fingers. Only a few muscles in hand, here and there. I think one of the key points that it goes over is like, we have to know the differences between like sprain and strain, things like that. You need to see which one gets hurt by like the ligaments, which one gets hurt by the tendons, which one gets hurt by the muscles, type of thing. The pelvic girdle, what happened? Oh my God. Forms the base of the torso and connects with the lower extremities. You have your pelvic bones from that form a strong ring. But however, if they do crack, if you do break, that's why they say a pelvic fracture can be very, very deadly. Why? Because that ring, if it breaks, well, guess what? You have a lot of bleeding towards that cavity. Let's see. You have the lower extremities consist of your hip, knees, ankle joints. We should already know all these right here. Let's see, we can get a little bit better. Patterns and mechanisms of musculoskeletal injury. The impact of the forces exceed the tissue's physiologic limitations. We have different injuries that can actually go down really, really bad from here. We have the common causes of the fractures. You have MVCs, falls, athletic activities, medical conditions. MVCs you already have. You can have your down and under injuries, or up and over, or even if you have like a rollover type, you get ejected. You can have either spinal injuries, skull fractures, open skull fractures. Your falls, the same thing. You can have hip fractures. Even for some reason, like if they have osteoarthritis, osteoporosis, they can crack their hips. We have athletic activities, your sprains. I know you mentioned that your dad does athletic trainer. There you go. So I'm pretty sure he can easily tell what's a sprain or maybe what's a strain. Those kind of things right there. Bone age, just like any other tissue. Decrease in density after the age of 35. That's where vitamins come into play. You want to come a little bit there. Eventually leads to your loss of height, accelerated in women once menopause has been reached. So, grandmas, every single time you see your grandma, they get tinier and tinier, shorter and shorter. That's one of the biggest things that's kicking in. Your mom, your dad too. Things like that, they start getting a little tinier and tinier and tinier. Why? Because density. Osteoporosis is a significant decrease in bone density, and it's associated with higher risk of a fracture. It hits them in a way where they lose like calcium, the bone density, any little thing. I've gone to many calls where they were just little ladies going, and as soon as they turn, they're just getting their groceries from out of HEB. That's it. One bad turn, and that's it. There she goes.
They step off the curb.
Yeah, or they step off the curb. Something really simple, but they're not really careful. They twist their ankle or something, and there she goes. Yeah, and that's it. Everything just goes down, and it's pretty bad. Right here, we have a pretty good deformity that you can see, but direct and indirect. I will tell you this right now, for those of you that are online or those of you that are here, you will get some sort of question here in your final. We have to know the differences between your direct and indirect. So direct occurs when the force of the object exceeds the strength of the bone, and you have your indirect occurs when a force is applied to one region of the body that is transferred to an area away from the point of impact.
So would you say like an excessive whiplash and breaking your neck, even though you're like I hit like I don't know the pelvis?
And would that be a direct or indirect?
With that, I think that's indirect.
Indirect. Yes, you are correct. You're incorrect. Whiplash, right? What about the big one that I like to say, the calcaneus injury. The calcaneus, the Don Juan syndrome. There you go. The Don Juan, the calcaneus. What about that one? What do you guys think on that one? If you guys remember?
Indirect.
Why?
Because it compresses the entire spinal cord, even though your impact's on the...
Money lands straight on the heels, right? And it goes and it compresses all the way up. Indirect right there. Those are great examples that I like to use. The indirect one, the calcaneus one. Because I can swear I've gotten questions like that before. So we have different types of fractures, and it occurs in the amount of force that overcomes the bone. You have like your hairline fracture, you have an open fracture, you have a compound fracture, different types of fracture. There's even one called like the fork fracture. There's different ways and different classifications that you have. There's many right there. Look at that. Right there. Maybe classified on the different type of displacement. Right here we do have a open fracture. Your skin is broken and the high risk of infection and blood loss right there. So would you put a tourniquet on that?
Yes.
Yes? Yeah, for sure. A tourniquet maybe right here on top, a little bit high and tight. High and tight, yes. That. You have to watch out. That is very painful. What else would you do? Palpitate the artery?
Oh, no, I was thinking of the actual artery that runs like
No. If we have this out on the field, what are we going to do?
Split in place.
Splint in place? Okay, I'll take it. What else?
Check for PMS.
Perfect. PMS is one, right? Always go basic and move your way up. Pulse, motor sensation. Okay, if you have no pulse, and if they're bleeding, if they're exsanguinating, we're going to have to what?
Stop the bleeding.
Stop the bleed. We're going to have to tourniquet. So if you tourniquet and you do PMS, are you going to have a pulse present? Probably not. Why? You tourniquet that leg. That's one. If that leg is still dangling for some whatever reason, you guys cannot perform surgery. It's considered surgery if you guys cut that skin. Even if it's just holding on by the skin, remember, you can't cut none of that. That is considered surgery. That is beyond your scope of practice. I mean, it's another thing if somebody forgot to carry the patient and then the leg just kind of rips. That's accidental, right? But no, we don't yank anything off. We keep everything in place. Splint and bandage as much as you can. Things like that. What about going further towards the call if you do have something like this? What would you do? You already said splint. You already said tourniquet. What else? Gimme.
Do like a baseline vitals.
Baseline vitals, okay. What do you expect to see on this type of guy?
Probably a low blood pressure.
Okay. What type of vitals? Give me something.
Tough.
What would be like a low blood pressure?
Low?
I think it's going to be a weak pulse, but high blood pressure comes to blood.
Kind of. I would say depends how much blood loss the patient has had. But from here, it doesn't look that bad. And if you control the hemorrhage, blood pressure might be a little bit high. Why? Because they're compensating right now, right? They're compensating. So that's one. maybe a tacky pulse. Depends, right? How bad your patient is. But I would assume maybe let's go more towards the tacky side, the compensating side for now. Okay. What would you do for these type of patients? What's your plan of action? What's your treatment?
Right away, we're gonna have to start some on them.
Let's start basic.
What type of treatment?
Yeah.
Every breathing circulation.
Airway, breathing, circulation. Okay. What do you expect to see on a patient like this on your airway?
Very stressed, breathing rapidly.
Stress, breathing rapidly. Okay.
I'll put like a non-rebreather.
A non-rebreather? Okay. Non-rebreather. What else? Remember, basic first, and then we move our way up.
And then, well, we said splinting, right?
Yep.
I'll also try to manage that.
Bandage. Okay. What else? Gimme. Basic first, Eric. Basic first. What else?
That's the only trauma the patient has is that one.
As of right now, that's the only thing I'm looking at right now.
So yeah, you would take care
Treat for shock.
the
What did we forget?
you have to put the thermal blanket on.
Blanky. Now we go Eric status, right? Now we go to hero. Now we start doing, what size of gauge would you start on this type of guy?
I'll put it.
18. How much? 1 or 2? Bilateral.
Maybe start with some TXA or something.
Okay, there you go. I like it.
With the coagulation process.
There you go. TXA, how much?
Oh, now that's a whole different story on the dose.
Okay, we'll get back to that. Okay, I like it. Lactated ringers you said as well? Okay,
I'll put that on.
there you go. Fentanyl,
There's a pain management.
pain management, fentanyl, how much?
So
What's the dosage? You know that one.
It depends on the kilograms. So what's the kilogram?
Okay, there you go. Well, what's your dosage? What's your
It's
action?
1 mic per 1 kg.
Okay, that's all I wanted. 1 mic,
Okay.
that's all I wanted. 1 mic per kilogram. That's all I wanted, just for now. Okay, you do have your close fractures. Look at this guy right there is waving at you in a different type of way. But close fractures, right? You're gonna have this school season, man, football season, soccer season. Best time to go get your splinting, your trauma game into play. Why? Because you're gonna be dealing with good things like this all the time. You can't go wrong. One of you guys are bound to get something like that. If you guys are just thinking you guys are gonna go have an easy check, that's the day that you think you're gonna have something like this.
You get the one that gets the colon quarters.
Yes, you get the one that has the comial cordis, and you best believe you were ready, right? Close fracture, that means nothing penetrated around. So the same thing. We start basic first. What is it?
Well, he's got no bleeding, so it's closed.
Mm-hmm.
You guys see his airway, it's probably going to be a little rapid.
Yeah, the same thing, right? It hurts. Broken bones hurt.
Airway breathing, if you want to, you can put SpO2, see where he's at.
Where will you put the SpO2?
I would put it, well, actually, can't you put it like on his big toe?
Yeah, that nasty toe right there?
Yeah.
You definitely can. Why would you do that?
Well, it gives you a better reading closer to the side of injury.
Close, but not quite.
Okay. Well, that was my message.
Let's think. Why would you want to put something there, the SpO2 there?
The circulation is like actually even reaching that
Money,
area. Okay.
right there. The circulation, the hemoglobin is still passing through. It's still perfusing those tissues. That's a good trick that you can do. The arms, the same thing. The hands and the legs. Yeah. Put it on the toe. Hey, I'm just going to put this on you. Sorry. Let's go. Splinting is the same thing. PMS, pulse motor sensation, C-spine. You know, let's go from there. We'll work it. Eventually, you guys are going to get to the IVs and all that, but that's already late in the game a little bit, you know? But it does hurt. If it's grandma and grandpa and for some reason it's the whole leg or whatever, that I understand. Start your IV, give them pain meds first, and then move them. If they're stable.
Decipher pain differently.
Broken bone, I would want pain meds.
Well, anybody would want pain meds.
Exactly. Look at that. Boom. Right here. What do you have? What do you have right here? What is this called?
A dislocation.
Possible dislocation. What else? If it's shortening, if we have some sort of shortening, and then towards the right or to the left, outward, you can see some type of shortening as well, maybe. Rotational. So signs and symptoms of your fractures, you're going to have pain, close sides, deformity, shortening, swelling, guarding is a big one as well. Tenderness, crepitus, exposed bone dens. I'm telling you, I was a black cloud for broken bones and cardiac issues. Those were my bread and butter. For some reason, I always had them all the time. All the time. I was looking through my Snapchat because I changed my phone, so I was seeing what things I had, and nothing but broken bones. So, pretty funny. Ligaments, ligament injuries, and dislocations. Mr. Prosek's bread and butter right there, more than likely. Key factors in determining a joint's range of motion. Shape of bones that form the joint. Tightness of the ligaments that holds the bone in place. Like I said, you guys have to know the differences between the strains, the ligaments, the tendons, what goes with what. Let's see. Dislocation is a big one as well. You have your subluxation, and then luxation, and then your, I can't even say that last one right there. You want to try it? There you go. Diastasis. Dialysis. You have sprains, the ones that we were just talking about right there. Ligaments are stretched or torn. The sprains, I will write this one down, or whatever it is that you guys can remember, because this is, I guarantee you, something like this will come out in your exam for your final. I could have sworn I read something here, very, very close to it. I will definitely look into it. Know the differences. Your sprains are the ligaments that are stretched or torn. Your typical symptoms include your pain, swelling, discoloration, unwillingness to use that limb. How do we even treat this? Sprains.
You're gonna
That'll be an ice pack.
Oh,
rice it.
your rice. Sacalation. Rice. Achilles tendons rupture. Injury related to inflammatory response. You have your bursats and your tendinitis. Let's see. Your strains results from a violent muscle contraction or excessive stretching. You might not have a deformity, but symptoms is minor swelling and increased pain with movement. So your strains are with muscles. Your strains are with muscles. And your sprains are with what? Your tendons and ligaments. Know the differences, guys. Know those two differences, please.
You can have a strain tendon.
So, so technically, a sprained tendon can be from dislocation and all that stuff too.
It can.
Yeah.
And that's why they always tell us don't put it in place.
Yeah.
Because you can rupture something in there. We're not orthopedic surgeons.
Yeah.
We're not ortho at all. So that's one of the things where, have I seen dislocations or have dislocations occurred when I'm there? Yes, but it's been more of by accident that they've gotten back into play when we're moving them, or like a psych patient that they're holding down. PD is holding down and they're moving and they dislocate their own shoulders. And then they put it back and I just start praying because that's scary. Because, hell no. I've seen a couple of those and yeah, that's not it. That's not it. Yeah. So, patient assessment. How will we approach patient assessment with these type of injuries? The same thing, guys, all the time. We already know our scene size up. Our patient assessment assess your what again? Level of consciousness, general impression, your ABPU, go A, B, C, D, E, whatever it is. But no, here, do you have life or limb-threatening injury condition, life-threatening injuries, life or limb-threatening musculoskeletal trauma, or some isolated non-life, non-limb-threatening injury? There's going to be different categories. I've gone to some where East Texas, like I mentioned all the time, they had a ATV park. And man, Jesus, I don't know what it was, but those legs and arms love to get in between those rims when they're flipping. And I saw a lot of gouged hands and a lot of gouged feet. And as it is not life-threatening, it just depends how bad it was cut. Because those gouges sometimes will cut everything clean off or mangle everything up. And the mangled ones were the worst ones. So you have to be very, very careful on those type of things. And it might be distracting. It might be very, very distracting. So are they going to die? Stop the bleed and find out, right? But you might have other more serious injuries that might be occurring. Scene size up, you already know. Focus on safety, standard precautions, BSI scene safe. Know your MOI. If you already have a broken injury in play, are you going to be considering C-spine?
Yes.
Yeah. Why? It's a high indicator. What happened? Was the impact was that hard for them to break a bone? Yeah. Where was the injury? Was it on the leg? Was it on the back? On the hips? On the head? Or like everywhere? Whiplash type of thing? What about you're going to consider there. Spinal mobilization, your potential hazard on scene, your PPE. What if this is like a rescue? You know, the hurricane thing just happened, right? What if those people were entrapped? And it's like a movie. They can't get out. They have broken femurs. They have broken this, broken that. You know, what are the potential hazards? I've done boat rescues where the guy has broken ribs, messed up thighs, and we're trying to also lift the boat. What are we gonna do? You know, it's one of those things where you can't move him. You can't move his head. You have to put a seat collar, and then you have to drag this guy out in a small 3x4 space. Yeah.
Not saying something, did you hear about that lady that crawled with a broken femur? Like,
Oh yes, I did hear.
That's crazy. Right?
That's crazy. Oh, we'll talk about that right now in a bit. We're gonna hit something that's very important on that. Primary survey, focus on mental status, your A, B, C, D, E, right? Prioritize. If you already know something is really, really bad, we'll go from there, right? We'll go from there. Stop the bleed. If you have open injuries, open femur fractures, whatever it is, more than likely we're gonna have to do a what? On open femur fractures?
Oh no, open ones you gotta turn to them.
More than likely, if it's still bleeding profusely, tourniquet. If not, don't mess with it. What is it? Don't be afraid of it. Just be aware of it. You haven't heard that one?
I've never heard that.
No? Okay. It's very famous right now. Significant trauma by multiple body systems. Make sure you have makes musculoskeletal injuries a low priority. Why? Because if you have somebody that was in a rollover and you have messed up hands, are you really worried about the hands?
No.
If they got ejected and they flew about 20 feet?
No, you're worried about their head. And, like,
Worried about the head? Worried about what else?
like the lung bones, if they have like any fractures.
Exactly. Your spinal?
Spinal injuries.
If they threw it, yeah. That's one of the biggest things that we've seen where a lot of people have those distracting injuries. Yeah, your hands are throwing up some weird gang signs. However, this guy's unresponsive. And it's like, don't worry about the damn hands. Yeah, that's the last thing I'm worried about right now. I'm worried about his mental status. Is this guy breathing or not? Am I going to be having some sort of ICP later? You know, am I going to have to get ready to maybe RSI this type of patient? Am I going to have to take over the airway? There's different types of things to go for. Don't get distracted. That's the bad thing about these broken bones. They can be distracting. If musculoskeletal injuries in extremities are suspected, stabilize. Stabilize, assess your post-distal, your PMS, the same thing, guys. This is all basic. You're going to come in, you're going to see and assess, and if it's not life-threatening, good. Hey, what happened? Pulse, motor sensation. We're going to see. If you don't have a pulse, can we try to align it? Only once. We know these answers. We know these answers. This is a good refresher right here. Open fractures can cause significant external bleeding. Use slow and steady. If it's getting really, really bad, bleeding may be difficult to control, use a sterile dressing and a compressive wrap. Get cold bands, you know. Not a lot, not too tight either.
No, but it looks like it's like really, really good.
Yeah, it's gonna mess it up, but just enough to cover the bone. Why? Because of what? If there's dirt that gets in there,
You don't want to risk infection.
infection. That, or you don't want to break up the. There's things that we have to. Right. Transport decision. You're gonna see right off the bat if this guy or this girl is really, really bad. You're gonna know. Oh, damn. Okay, let's load and go, load and go, load and go. And you already know that. Assess your airway, breathing, circulation, and we'll do everything else in route. Patients with simple MOIs may be stabilized prior to transport. However, the ones that are unstable, stabilize as best as you can. You know, probably SMR if that's within your protocols. And let's go. Let's go from there. History taking. Try your best to get a sample history. Why again? Why?
What was the question?
Why is it important for us to have a sample history on these type of patients?
So you know, like if they have any, well, because never mind, that's not what. Like that.
Talk to me. Talk to me.
No, but because there's gonna be like certain type of medications and stuff that you're gonna have to like know that can counteract what they have.
That's exactly what I was
Like,
looking
if
for,
you have,
Prozac.
like a patient with like blood thinners.
Exactly.
and they have, like,
Blood
a
thinners.
Really bad like exudation.
Okay. What
you
else?
have to like think of something else.
Blood thinners is one. What else? Give me.
I would say like.
Gimme,
if
gimme,
they're-
Casey.
If they're like diabetics.
Okay. Money. Diabetics. What else?
Like, deals with like.
Why? Because trauma patients use a lot of what?
Glucose.
Glucose.
I use a bunch of everything.
Exactly. What else? What else? Give me something, Casey. Give me something. Throw me something. Not your phone. Throw me something.
Close the book.
What else?
That's oral.
Justice, what else? Come on, come on. What is
What
it?
happened?
Me and you, me and you.
What led to the event? Like,
What led? What other medications am I looking for?
Oh, you want medication?
Yes.
Okay.
Well, medication just for the broken bones?
Nope. Remember, what controls
So
your...
you want like the history type?
What's important from the medications on the history?
So I will say blood thinners is a big thing.
You already mentioned blood thinners. Give me else. Give me something else. Give me something else.
Is there like allergic to medication?
Okay, that's another one. I'll take it. Ain't what I was looking for, but I still, I got it.
Wait, no, what's the question? I don't understand.
What's so important about history taking on the medications for these type of patients that are in trauma?
Oh. Oh.
Pain management? I mean,
No, it's just side effects. So, like certain medicine can.
Certain medicine can give you bad side effects.
Yeah.
Or if they have a history of high blood pressure,
Hypertensive?
they can be hypotensive,
oh, yeah.
and it's a nasty injury, but what's the reason they're hypotensive? Because they took their medication. So the medication's working, however, you think this guy's going down. Or you think this guy's dying, when in reality, they're just a little too relaxed because of their medication that went on. Your calcium channel blockers, your beta blockers, things like that. What if you see a low heart rate on this guy that got a double amputated legs? Like amputations cut clean, broken bones, mangled bones on the bottom of both feet. And you're like, what the hell, man? This guy's decompensating already. His heart rate is like in the 50s and his blood pressure is like 70/40. I need to give this guy like some vasopressors and fluids like right off the bat. Why are we going to do that? And then you ask the history. Oh, sir, do you take any medications? Yeah, I did have a heart attack, and I'm on beta blockers. I'm on this. I'm on that, and all those things. The ACE inhibitors.
That explains why you have a little bit of a low.
Exactly. That would explain why we have low heart rate and low blood pressure. Remember, those are the things that we need to watch out for in the medications with trauma patients. The medications you need to know, and if you don't know, you have your phone now. Dude, you guys have ChatGPT. You guys have all these things. You can literally look it up and like, oh, what does Metropolo do? What does this do? What does this ACE inhibitor do? What does Lucinopro do? You remember, your LOLs are your beta blockers. Your LOLs, and then your Lucinopros, your Pearls, are your ACE inhibitors. Those things can mess up your heart rate, or not messing up, but keep your heart rate down and your blood pressure down. And if you have a trauma patient that you know this patient, you're expecting like the foot one. Oh, I'm expecting this guy to be compensating. Heart rate really high, blood pressure high, and then boom, you get like the best blood pressure ever and a little low heart rate.
It's perfect.
Yeah. So it's like, oh, I have a unicorn with a messed up leg. No, it's not that. Remember, it's very important to ask a history. It's important to know your whole assessment for this reason. These medications can mess you guys up. What if you guys go to the hospital and they tell you, oh, they look them up and all their history comes out and it's like, no, dude, this guy needs surgery right off the bat. And you didn't prepare. You didn't give him anything on that. That's one of those things that it can come back and haunt you. Always get your baseline vitals compared to the injured extremity with the uninjured extremity. Perfect example that I was mentioning, the SpO2. You have it, if you have an SpO2 of like 90, ooh, does that mean that the patient needs oxygen or it's just that extremity?
That's why you do the other.
That's how we compare. If the patient's SpO2 is at 97, 98, good. But then you move it over here, SpO2 is of 90, circulation, perfusion is not going that well. There's something here. Something going on, right? Now we know. You have to cover your 6 P's right here. You have your pain, paralysis, paresthesia, pulselessness, pallor, pressure. You have your pain. Remember the OPQR is the mnemonic. You guys should know this already, right? Ask the patient from a pain rate from 0 to 10. 10 being the worst. 10 being the worst. All these things that you can see with the broken bone. Do you need to remember all these? I would say yes, because you can have just one of these things. You might have like a little bit more of a pallor, or you might even have the paresthesia. I can't even say that one. Or you might have like pulselessness, things like that. And always check. We're looking for DKP-TLS, but not just DKP-TLS, right? We have deformity, skin changes, swelling, muscle spasms, abnormal limb positioning. This one right here. I've gotten a lot of, like, questions or things like that. We're like, oh, well, how do you even splint a shoulder injury? Okay, well, if the shoulder is just like this and it's just giving you like a weird thing, are you guys gonna move it? No, leave it in place as best as you can and stabilize it the way it is. You guys are gonna have to adapt and overcome that type of thing. But now, let's say you do get a broken elbow or a broken forearm, and the guy's like this, or the girl, like, and they're like,
Well, the shoulder's fine.
the shoulder's fine. Don't forget about that. Oh, okay. Sling and swap. Sling and swap. You'll be surprised how many people don't want to move it and they just want to stay still because it hurts really bad. But just, talk to them. Give them something to hold. Here, hold your hand real quick. Palpation is a big thing. Check for point tenderness. Identify instability, deformity, abnormal joint or bone continuity, and displaced bones. Feel for crepitus. Palpatable distal pulses. You want to compare sometimes, Palpate pelvis and upper and lower extremities. How do you check for a pelvis injury again? We're going to be doing PHTLS next week.
Slightly compressed on the side.
Slightly compress, or even you want to pull. You can even pull towards yourself.
Or you can go up and down like
Mhm.
yeah.
Yep. And as long as you don't get an you're good. And you will feel when it's broken because it will feel out of place. Yes. You will feel that and you're like, oh. And how do we treat that? Pelvic binder. What if you don't have a pelvic binder?
You just get a bunch of sheets.
A bunch of sheets or just one
You
sheet?
can diaper them.
There you go. Just get one sheet, and boom. Or if it's a big person, you can double it up. Double it up and then give it to the next person. No. Yeah. Motor function sensory exam. Check that the patient does not have a life-threatening injury. Consider the pre-injury level of function. If they're already telling you, like, oh, I can't feel my hand, or it feels numb, tingly sensations, that's one of the ones that are like, oh, okay, well, let me check if you have a pulse type of thing. And if you don't, you try to realign, right? And you still don't get a pulse, what does that mean?
There's either nerve damage or the blood's not perfusing to the tissue.
There you go. It's kinking something, right? This is all basic, guys. This is a good refresher. Good little refresher for the basic. I just want a little bit more sometimes. The condition of the injured extremity requires regular reassessment all the time, guys. Repeating the neurovascular exam periodically will allow you to recognize the development of the neurologic defects, if there's anything. Or, boom, compartment syndrome. That's where I'm heading at. That lady that you mentioned, within 24 hours, she could have been a big compartment syndrome patient now.
Yeah, I was like, what was she, like 40? It was like 24, 40? There was something.
Yeah, it was pretty bad, man. Pretty bad.
All like 14 miles.
All right, so emergency medical care. We have our general treatment. Whenever we have a fracture, we should already know, right? We have, stabilize, check PMS, splints if we can, rise it, and then we start moving towards the ALS, right? Then we start moving towards the medication. Remember, BLS before ALS all the time. BLS before ALS all the time, guys. Remember, get your stuff first, splint, and then start your IV. Just because they have a broken bone doesn't mean that we have to start bilateral IVs. Just one IV, and give your pain med if you want. Give your pain med if you want, whatever you guys decide. Prevent hypotension and instability as well. Apply pressure, splint, administer your IV fluids. If you suspect a femur fracture or even a pelvis, remember, give some fluids, but how much? How much of fluids are you guys going to give?
20 times their kg.
20 mLs per kilogram. Is it going to be open wide?
If it was in closed or open people,
Either or.
well, you don't wanna open it all the way because then you just lose the back clot.
So what is the term I'm looking for?
So,
TKO.
to keep vein open.
To keep vein open. That's it. That's it. Remember, never fully open all the way, right? We're going to be making Kool-Aid. We don't want Kool-Aid. I don't want no Kool-Aid. Pain control. Assess the patient's pain level. Splint, rest, elevate. Heat or ice if needed. If all, administer analgesic or antispasmodic agent. We use more of the analgesic effect. Morphine, fentanyl, your pain medications. What's the dosage for morphine? What's the dosage for morphine? Okay, see, I thought you were gonna bust out a vial right there. I was like, damn, bro.
It's 0.3.
0.3?
No, I think it's still 1 milligram per kilogram.
For morphine? 1 milligram?
Chick-fil-A?
I don't know. I'm not sure if Tony's still in there or any of my other guys online. What's my dosage for morphine, guys? What's my dosage for morphine?
It's not on the RSI protocol.
It's not on the RSI protocol? Aw.
Oh.
Aw. What else? What else? Man, I got you guys looking.
This is what I'm gonna whip out in the magazine.
2 to 10 milligrams. 2 to 10 milligrams. 2 to 10 milligrams. Depends what you guys want to push. You guys are the medic at the end of the day. 2 to 10. That's the general. That's the general, right?
Oh my God, yes, we did that scenario.
Yes, yes, yes. What about fentanyl again? You know fentanyl?
That was 1 micro 1 kg.
Okay, there you go.
And then it was I remember the morphine now because we had Ashley and she was all small. So you're like, I was like, let's do 8. You're like 8?
Okay, there you go. We have cold and heat application just in case if we do have an injury. During the first 48 hours, cold packs to reduce the pain and the swelling. Heat therapy should be avoided in the first 48 to 72. But then it can be used to increase blood flow and decrease the stiffness. You want to dilate those veins. That way you can reperfuse the injured part. Splinting decreases the pain, reduces risk of further damage, and controls the bleeding. I had many EMS colleagues back in the day that wouldn't do pain meds, no splinting, no nothing. They were just like that. And one of the things that I've learned along the way is that you feel the nasty bumps in the car ride. So that's the one that hurts a lot. Let's see.
You have like resting on your waist, you hit a bump. Ooh.
Yeah, exactly. So all those potholes, all those bumps, all those stops and goes, those stops and go hurt. Splint, please. Splint, splint, splint. It doesn't hurt. Splint. Just go and do your splint, and then from there ice pack it, and give your pain med. You guys are gonna be paramedics. Don't be lazy doing because you guys don't want to do the paperwork. Principles of splinting. You guys should already know all this right here. We should know. Let's see. Mira, papita, guys. You guys know this one right here, sling swells as well. Papita. Mira. Even with a pillow, damn, customer service all the way. Our pneumatic splints, I love these. These are becoming very, very bigger now. You can actually slow down the bleeding, or you can even stop a bleed if it's like an open fracture. You can actually stop the bleed within there. It's pretty cool. Wesakov has them. I think Mercedes has them. I think Steck has them as well. It's getting bigger. I'm not sure if Medcare has it. I haven't seen Medcare have it. But I think FAR might have them as well. So yeah, I'm not sure if our Skyline guys have them or not. But yeah. Oh, this vacuum mattress right here. The vacuum mattress. This one, guys, game changer, bro. Whatever you have, if you have like a hip fracture or something like that, this is very, very helpful, especially for your big patients. It kind of makes it a cushion and doesn't hurt that bad. Let's see. We have our traction splint. When do we use our traction splint?
Isolated femur fracture.
Isolated femur fracture only whenever you have a mid-shaft femur fracture only. If you have multi fractures on your legs or wherever, don't. This is a no-go. What is the other biggest splint that you have?
The backboard.
The backboard. Backboard it is. Backboard it is. Your buddy splinting for your fingers or your toes, right there. And then you're just giving peace sign or whatever it is to everybody else. The alien one. I come in peace. All right. Pathophysiology assessment and management of musculoskeletal injuries. Likelihood of complication is due to the strength of the force that is caused by the injury. Location of the injury depends where and the patient's overall health as well. Let's see. Paramedics can reduce the probability of long-term disability by preventing further injury. Spinal injuries, dragging the patient out, not doing your C-collar, not holding C-spine is big. The only time is like in an emergency move. But other than that, somebody should be there. Somebody should be there. And you see how this can actually, you can actually cause more damage if you don't do something well enough. That's why the controversy of like backboards now, you know, some people are like, oh, backboards all the way, some are not. You know, it all depends on the protocols and the studies, but whatever it is, as per Nancy Caroline, she's kind of like in a dark gray area, they say yes and no. It all depends on your protocol. So wherever you guys end up, you know, that's where it's at. Reduce the risk of wound infection as well. You guys already know this. I say it all the time. If it be clean. Be clean. If you have broken bones, if you have nasty gashes, bandage it up and try your best to prevent infection. The same thing when you guys are going to intubate. The same thing. If your tube falls down or if your tube is somewhere else and it's not an aseptic technique, get a new one. It doesn't hurt the patient. You're hurting the patient more if you just take that one out, you try to clean it or you try to troubleshoot. No. You guys are going to cause pneumonia for sure. Bacterial pneumonia, you guys are going to end up getting your patient. So always be clean about your stuff. Devascularization on your peripheral nerve injuries. When blood vessels are damaged following a musculoskeletal injury, loss of blood flow can occur in the body, part supplied by that vessel. And you also have your neurovascular injuries. Occur when the shoulder girdle or proximal humerus is fractured. Right here, and or the little wings, my bat wings, right there, on the very back. This is more likely to occur in a joint dislocation. Assess and manage. You can perform your neurological exam, make sure everything is good, but please don't try to put it back together. Like, oh, you know, I saw this, I saw that, you know, pull. We don't do none of that. No. Compartment syndrome. A condition that occurs when pressure is too high within the fascia. Causes include over-tightened bandages, splints, casts, bleeding within the compartment due to a fracture. Boom. Those femur fractures, like you mentioned, the lady, 24 hours right there on the floor, you know, with a broken bone, fluids leaking or edema, that's one. Bleeding within the compartment due to a fracture, that's another one. Big time compartment syndrome right there. And remember, it kind of goes hand in hand to all this, right? You're going to get that lactic acid, that acidosis is going to start creating, and it's just spreading. It's going to be spreading towards the fascia, and then it's going to be spreading everywhere, and it's going to start killing that tissue. That tissue, yes, that tissue, and it just starts spreading everywhere. And that is very, very bad. Assessment, the first sign of searing or burning pain out of approaching in the injury. Your neurological symptoms include I can't even say that word. What is it? Paresthesias? Sure. Paresthesias. Paralysis of involved muscles as well, and postlessness is a late sign. So postlessness is not good. Whenever we actually get a broken bone, you know, and they've been there for 6 hours, 7 hours, they can't call, and you're doing a routine check, and boom, you find these patients like that. Keep in mind, compartment syndrome can be a very, very big thing. Elevate the extremity to the heart level, apply cold packs, open or loosen constrictive clothing, administer a bolus of isotonic crystalloid solution. Normal saline. Isotonic solution, normal saline. Whenever you do have like a crush syndrome, the crush injuries, which I think is the next one. Yeah. Those are the ones that we have to watch out for. Going for this. Right? I mean, this one too, compartment syndrome is bad too. Okay, crush syndrome. Results of a prolonged compressed force that impairs the muscle metabolism and circulation. After 4 to 6 hours, compressed muscles begin to die and release contents into the localized vasculature. So from there, renal failure does occur. Serious complications that may develop after releasing of crushing forces. Always assess your ABCs, even on a crush syndrome. Machineries, you're going to see it all the time. One of mine and Mr. Salinas' colleagues, a long time ago, he had a person they were doing something and the machine just dropped on both hands. Yes, So the hands look like, when they took them out, they look like thin paper. Thin paper. It was crazy. And the same thing, could he start lines? He couldn't. Both arms were out.
Oh, well, no.
Both arms looked like thin paper. He couldn't start lines. So yeah, right? Imagine. The one vein that's good is just looking at you solid, and he still blows it. Oh. No. He went to the IO and he kept working. But yes. And stabilized cardiac monitoring. Why do you think cardiac monitoring?
Is what pressure is done? Well, you can see if that lactic acid is affecting the heart and the perfusion of the heart.
How?
Like the capillary muscles.
It's getting there, but how? Why?
It will end up just killing the muscles, the tissues that are around the muscle,
Okay.
and slowing it down.
I mean, yes.
It's losing its work rate.
Yes, and no. So you're on the right track, but it's like those electrolytes. You're losing electrolytes. It's going off. The same thing, the kidneys. You're going into kidney failure. You're getting the lactic acid buildup. Not just that, but you're also getting what? Potassium. You're losing potassium, or a lot of potassium. Hyperkalemia starts getting into play. And that is what sends the heart into a messed up overdrive. Why? Because they have too much potassium in their heart, or too little potassium in their heart, and you're going to start seeing some electrolyte imbalances. And you can, on that EKG, you're going to start seeing some weird things come around that you guys are going to learn next semester. Maybe some PVCs, and then patients start slowly converting into VTAC, where you start seeing some nasty wide QRSs, and your patient's already going down. And it's like, oh no, like what? Why are you doing this to me? You know, type of thing. Ooh, very close to rhabdo, but yes. Very close to rhabdomyolysis. Yes. So, right here. Renal failure. One of the biggest things that can actually happen. So what is the difference between Crush syndrome and compartment syndrome? Tell me.
Crush syndrome affects the entire body.
Which one?
Crush syndrome it affects the entire body.
Crush syndrome affects the entire body. How?
Once you release the pressure from the
Perfect. Once you release the pressure, it's going to go. And what's going to be released?
the lactic acid.
Lactic acid all over the
All the
place.
way in the bloodstream.
And it gets where as well?
Into the kidneys, and they're going to try, the kidneys, they're going to try to compensate, and then over.
Money. Good job. Thrombolytic diseases includes deep vein thrombosis, pulmonary embolism. Signs of a DVT, disproportionate swelling of the extremities, discomfort in the extremity that warrants the use, warmth and erythema of the extremity. You're going to see it hot, red, that one big cankle that you just want to smack. Pah! But careful now, you don't want to smack it too hard. Why? You might just disperse that clot, right? But this one is just going to look all fat and nasty, but this one looks all nice and normal. You know, perfect leg. But this one on the right, not that good. So you have to watch out for those type of things. Signs and symptoms, pulmonary embolism include, you guys already know or should know, boom, these. Shortness of breath, tachycardia, low-grade fever, right-sided heart failure, shock, cardiac arrest, the worst one, right? Big one, just a little bit. Treatment of pulmonary embolism, maintain the airway, adequate oxygenation, intravascular volume. Provide rapid transport towards the ED. How do you know if you guys are working a cardiac arrest? How do you know if it's in pulmonary embolism?
It was a pulmonary embolism that started.
Or you can suspect that it's a pulmonary embolism.
You have the swelling in the ankles.
Okay, that's one.
You have
Or just the swelling on one ankle, right? Or one of the legs.
the skin surgery
Skin tugger, where?
in the outer extremities.
Where?
Outer extremities.
Outer extremities. Okay, what else?
Purple around the lips.
Purple around the lips.
And they're multiple.
So if you, like in a cardiac arrest, one of the things that I've seen is, and I've done it myself, put the SpO2 on. Ooh, was somebody going to say something?
Yeah, somebody will have their hand raised on the camera.
Talk to me, Tony. Say it, Tony. Don't be shy, Tony. Come on, Tony. Speak some truth, Tony.
I think he's gonna type it. I don't know if his mic works. I don't have a question, trust. It was an accident.
It was an accident. Nah, man, Tony. All right.
I did want to add something real quick. Y'all were talking about compartment syndrome, right?
Yes.
Something about compartment syndrome, not only does it reduce acid, it also reduces myoglobin, which also affects the heart or kidneys. And that can shock the heart itself and into hypertrophy. That's why we give sodium bicarbonate, calcium gluconate. You can also give albuterol to combat also acidosis.
Esto. That's our third semester paramedic. Oh, actually, capstone. I'm sorry. Capstone. He's capstone. So good. Very, very good, Tony. So how do we know about the pulmonary embolism, though? That's my question. I like that one, though.
No, exactly.
How would your index of suspicion be going towards there?
So pulmonary embolism, so one of the things is that if you're giving O2, the SpO2 is not going to be able to read. It's just going to stay at a constant. Let's say you started at 86, it's going to stay at 86 because there is no perfusion going or diffusion going on because there's a clot. So no matter how much oxygen you give, it's not going to work because there's a blockage.
Hell yeah, exactly.
I'll see you next Wednesday, sir.
Exactly. No, great job, Tony. Great job. Exactly that. So even when you're working a cardiac arrest, you guys can actually put the SpO2 on. You guys can intubate. EtCO2s may be exchanging just a tiny bit. EtCO2 levels can vary, depends on the pulmonary embolism, right? But your SpO2 levels, the perfusion, like how he mentioned, it's not going to catch. So you might actually even see like a full line where their heart is of white, and then right here on the bottom, red. Why? Because right here towards the bottom, it might be actually perfusing, but from where that clot is and up, it's not perfusing anymore. So it's really good to see that and to actually read it whenever there's a cardiac arrest. Next semester, when you guys are there and you guys are cleared, and you guys hopefully, well, I'm not saying hopefully, right? I don't want nobody to die. But in this type of way, practice that. Go and put that SpO2. It only takes, what, like 5 seconds? Put that SpO2 on and monitor that SpO2. It can give you some feedback as well, especially once you intubate your patient. You have your real-time data, which is your EtCO2, right? But then you still want to see if that oxygenation is still going and perfusing. You want to see that hemoglobin too, right? You want to see everything that's getting perfused? Yeah, you want to see it. So it's good. Justice over there like, no, it's good. It goes a long way. It goes a long way, trust me. Let's see. Pathophysiology assessment and management of specific fractures. That was awesome. Thank you, Tony. Appreciate that. Thank you. The shoulder griddle, that's what I'm going to call it, the shoulder griddle, consists of your clavicle, shoulder, and your scapula. Right there. Clavicle fractures are actually really, really easy to break. That's one of the most common one, actually. Pain in the shoulder, swelling, unwillingness to raise the arm, tilt of the head towards the injured side, and usually you might see it. I myself has been a victim of one. I've had surgery for one, and you have to just, how would you splint it? There's different types of splints that you guys can use. Sling and swat is the most basic one, but there's also one that goes around the neck, and it actually, or even on the back, you do a little crisscross, and it actually stretches it out, and it keeps the back straight, and the bone gets stretched out. Yeah, it gets put in the neutral position. As long as you guys learn to splint it well, then you guys are good. Remember, basic first. We go basic first, and then we'll make our way up. But pain medication is one of the ones to go for, right? The what?
Those are so funny.
Let's see. Management, we already know what the management is. We already basically went for it. But assessment, it does not change, guys. It does not change. You're looking for your decapitals. If you have any deformity, crepitus, things like that, check for PMS all the time. Check for PMS all the time, and then you go from there. Work your way up. Rise it, splint it. Start your IV, maybe 18 gauge, 20 gauge, 22 gauge, whatever it is that you guys want to get. As long as you guys get a line, right? As long as you guys get your line, and you go from there. You give your pain management. Let's see. Distal humerus for your elbow fractures. Supracondylar, supracondylar fractures typically occur as a result of the falling onto the outstretched hand. Proximal radius and ulna is the most common one, I think, right here. Radial head occurs as a result of falling onto the outstretched hand and forms a direct blow. You get your, right here, the forearms. Signs of a distal humerus fracture: pain in the elbow, significant swelling, ecchymosis. Can we tell what part of the broken bone? We don't have full x-rays, but you can have just a general idea of where it's at. Yeah, just the anatomy of where it's at. I've had some where I'm thinking I'm working a mid-shaft, fracture, because it looks all torn, and it turns out to be like the head of the hip or things like that, where it's like, what the hell? As soon as you go into the x-rays, I'm like, you see it, and it's like totally something else. I'm like, what the hell? Yeah, I was like, no. And it's one of those things, well, what happens? We don't have x-rays, but you can go based off of everything that you can and you can go for. It's, we're only human. We're only human at the end of the day, Let's see, forearm fractures, the same thing. You have your direct blow, falling onto the outstretched hand. Let's see, I think we are done though, guys. Let's see. Oh, pelvis fractures. Let's see. Oh, you have to watch out for these right here. So I guess let me go over this one. Disruption of the pelvic ring occurs secondary to high energy trauma. If a pelvic injury exists, suspect multi-system trauma all the time. Why? Because if it was hard enough to break the pelvis, more than likely you might have other types of injuries as well. And just know that if you break your pelvis, there might be other injuries as well, going for your bladder, the urethra, even the rectum, vagina, and the sacral nerve pulses. So those things can get affected if it's really, really bad. One of the big ones that you might see is, especially in a multi-system trauma, is that they break it's a rollover, they break their hip, and they say, and they're still responsive, and like, man, I really need to pee, or I really need to poop. And it's like, bro, you don't want to do that. Why? It's going to be nothing but blood. And they're like, oh, I can't hold it. And then they start going and they think they're peeing. When you don't want to tell them, but it's nothing but blood. It's blood. And you're like, oh, no, you can't plug that one. So it's one of those things where it's like, okay, they're going to just be bleeding out. So that is not a good sign, right? So, I'm not even going to say that without Yes.
You just heard what I said, bro.
Yeah, you should have heard what Dalton over here said. But yeah. Don't criticize me, Eric. Please don't. Blood vessels most prone to damage. Veins within the pelvis. Nerves are the greatest risk of injury. Those are in the lumbar or the sacral, right here in the lower back. There's sciatic and your femoral nerves. Everybody that has been in a car accident, they send them to therapy, right? And one of the big ones, even when you get your patients that are complaining of back pain, like, oh man, my sciatic nerve has been messed up ever since I was in a car crash. That is the big one. But it's one of those things that they got hit on the lower back and that's it. That nerve got pinched or it got hit just in the right spot, messed them up. And there's no coming back from it. There's no amount of therapy that can bring you back, no amount of injections that can help you. That will unfortunately stay with you, and it's one of those things that sucks. Even us as EMS providers, that's why we tell everybody, lift right. Don't be messing around, and if you can't lift, ask for help. Ask for help, because the last thing you want is one of these right here. The sciatic one, that's it, game over. It can be a career-ending injury. And now you can be here like Mr. Flores teaching later on. No, I didn't mess up my back. Yeah? So look at that. Lateral compression, pelvic ring disruptions. It's results on the side, but right here. You can see it right here. I think you guys have it in the book, right? You have it in the book? Yeah. They say, I've seen a couple of these, and they say that as long as you keep them in a certain position, that it doesn't hurt. But they kind of were not fully on it. The ones that I've transported and I've seen this, I've had her on the side, lean on it, and they were okay. I wrapped them on a taco when I like did everything. I did the whole bowl, and she was fine. She said she didn't feel pain or anything like that. She didn't even want pain medication.
Yeah.
So it was crazy.
I've seen one in Australia that was that he just like fell, like completely dislodged his pelvis,
Yeah.
and he was just sitting there all calm.
Yeah, and that's why I was like, are you sure? Like that the shortening of the leg was there, everything was there, and I was like, Jesus Christ. Yeah, but lower risk of hemorrhage. Yeah, they didn't really feel it. Like I didn't I just saw the shortening of it, and I was like, oh, something's up. But full still had a little bit of range of motion, slight pain whenever we would move them, but other than that, they were a-okay. So it was crazy. Let's see. Vertical shears, that's another one, occurs when a major force applies to the pelvis and it results in increased pelvic volume. Your straddle fracture as well, there's many different ones, occurs when a fall, when a person lands into the region of the perineum, carries a risk of complications when they basically fall in their behind. The tailbone, the one of those. Open pelvic fractures, Jesus. This one is a life-threatening hemorrhage within the injury of the major vascular structures. If you see something like this, more than likely it was either a penetrating or a blunt trauma that was like bad. One of those things that was pretty, not too great, man. Results in chronic pain if, for whatever reason, they are able to survive that. That's crazy. But more than likely it's going to be permanent disability or death. Let's see. Signs of a stable injury include pain in the pelvis, difficulty bearing weight, but they're okay. Signs of profound injury include profound shock, gross instability, diffused pain, possible bruising or lacerations, possible hematuria, blood in the urine. Signs of a vertical shear include significant shortening of a limb, possible massive hemorrhage into the pelvis. Bleeding is seen into the rectum or vagina should increase your suspicion of a pelvic fracture, like I've mentioned before. If they tell you, man, I got to pee or I got to poop, it's not that, man. More than likely, you're going to be bleeding.
So it's almost like you have like a spinal injury in your neck and bleeding in your ears and nose.
Vesicular fracture.
Same principle almost?
Could be, but that's the one to watch out for. Whenever, if you guys are dealing with like a multi-system trauma, just don't tell them, yeah, go to the restroom. It's okay. Try your best to withhold it, because once they start peeing, that thing does not stop. It goes. And your patient's bleeding out, and like I mentioned, you can't plug that hole. So they're going to just be bleeding out. And it's hard for them to actually stop after that. So more than likely, you guys are going to be dealing with a cardiac arrest if that does occur. The times that has happened to me, patient has gone into cardiac arrest. So there's nothing we can do.
It becomes like a constant flow, like of just blood coming out?
Yes, sir. Yeah. After like that's what you're saying, like, no, hold it. But if they can't, it's called an exsanguination. They're dying. Yeah. And even then, like the bladder inside more than likely is ruptured as well. So you can't stop it. They're bleeding inside, and now it's outside. It's just overflowed. Yeah. You guys should already know, primary survey, if you guys ABCDE. Assess the pelvis for bleeding, lacerations, bruising, and instability. We should already know, we're going to go over PHTLS. One of the key points is pelvic binder is a big one. We're going to be going over it next week. So you guys have it there. Monitor your ABC, spinal stabilization. IV access is a big one. Try your best to reduce bleeding by pelvic binder. One of the biggest things, if you guys do give pain medications, what is one of the biggest things that I'm telling you guys already as it is?
Watch the vitals.
Watch your vitals, especially what?
And put the ETCO2.
ETCO2 is all the time. If you guys are going to give narcotics, ETCO2 is the way to go. Real-time data. And remember, if they have hypoventilation, what are we going to do? What are we going to tell these patients?
Just slow down and
Breathe. Don't forget to breathe.
Yeah.
If they have hypoventilation, ETCO2 is rising, well, hey, don't forget to breathe, man. It's okay. Don't forget to breathe. Why? They're a little too relaxed, maybe. And that's it. That's it. Don't freak out. You'll be amazed how many times that happens. There it is. That's it. Let's see. I think we are done, guys. Let me see. Yeah. No, we should be good. No, yeah, we're good. No, yeah, we're good after this. All right, guys, we're good with this one. That is it. Actually, you guys have a good one. We are done for the day. For those of you online,